Hi friends, today I am going to discuss a condition which Amitabh Bachchan himself had suffered once. You might have recognized or probably placed it correct. It's Myasthenia gravis. Friends, Myasthenia gravis is an autoimmune disease of neuromuscular junction. Antibodies to the acetylcholine receptor may reduce the absolute number of functional receptors by direct destruction of the receptor, blockade of the receptor, or complement mediated destruction. Myasthenia patients present with generalized fatigue, weakness that worsen with repetitive muscular usage and improve with rest. Extraocular muscles are very commonly the first affected muscles, and the patient complains of diplopia or ptosis. Of particular concern are myasthenic patients who develop weakness of the respiratory muscles and the muscles controlling swallowing and the ability to protect the airway from aspiration. These are the problems. Cholinesterase inhibitors, corticosteroids and other immunosuppressants are very effective in treating myasthenia gravis. The thymectomy results in remission in a majority of patients. Physiologic stress such as acute infection, pregnancy or surgical procedure can lead to exacerbations of myasthenia gravis, friends. Principal concerns which include the degree of pulmonary impairment, the magnitude of bulbar involvement with attendant difficulty managing the oral secretions, and adrenal suppression because of long-term steroid usage are huge concerns for anesthesiologists. Patients are usually resistant to succinylcholine. However, the degree of resistance does not appear to be great clinical significance, and increasing the dosage of succinylcholine instead of 1 milligram or 1.5 milligram, you just give 2 milligram per kg, that results in satisfactory intubating condition. Myasthenia patients are more sensitive than other persons to non-depolarizing relaxant. The dosing of non-depolarizing relaxant should start at about 1/10 of the normal dosage. Recovery time for even those reduced doses could be quite prolonged. So often during induction, preferably no muscle relaxant is better to be given. It can be easily be intubated without anything because the patients are already weak. Just plain volatile anesthetics is more than enough for suitable muscle relaxation and even intubation. So friends, once again I would like to tell some more things about this interesting myasthenia gravis. It is an autoimmune disorder that results from destruction of postsynaptic nicotinic acetylcholine receptors located at the neuromuscular junctions. The interesting part is the patient with myasthenia gravis are found to have nicotinic acetylcholine receptor antibodies. Although it is notable that neuronal nicotinic receptors are left unaffected. This indicates that the disease affects mostly skeletal muscles. So I'm sure you would agree to it, and the prevalence is almost 1 in 7,500 patients. The classification, as I had mentioned earlier, that based mostly on ocular symptoms and non-ocular weakness. Besides ptosis and diplopia, bulbar involvement is common, which will affect pharyngeal and laryngeal muscles. Interestingly, there is something called myasthenic crisis, and the strength will increase following the administration of adrophonium. The tensilon test is contraindicated. Then you have to do ice test to confirm whether it is myasthenia gravis or not. An ice pack is applied to the affected upper eyelid. Very few people know about this. ICE test in place of hydrophonium or tensilone test using physostigmine to confirm myasthenia gravis. An ice pack is applied to the affected upper eyelid for 2 to 5 minutes. A positive test is the improvement of ptosis by increase by more than 2 millimeter or more. This transient improvement in ptosis is due to the cold decreasing the acetylcholinesterase breakdown of acetylcholine at the neuromuscular junction. Ain't it? It's very interesting, friend. Very few people know about it, but I am sure you should be interested to know about it. And the concern thing which I would love to share with you is the Leventhal scoring system. This is basically for a particular risk, whether there is a post-operative requirement of mechanical ventilation or not, if you see the Leventhal scoring. Most of the patients undergoing surgery with myasthenia gravis would require post-operative ventilation. So for mechanical ventilation, for that risk factor, we have Leventhal scoring system. Risk factors associated with increased likelihood for post-operative mechanical ventilation include duration of disease greater than 6 years, coexisting pulmonary disease, pyridostigmine dose exceeding 750 mg per day, and preoperative vital capacity of less than 2.9 liters. So this is the thing which gives you an indication with the scoring whether there will be requirement of post-operative mechanical ventilation or not. And one thing which is always confused with myasthenia gravis is LE. LE is Lambert-Eaton syndrome, myasthenic syndrome, which is often confused with myasthenia gravis. But if you see, it's its own distinct entity compared to myasthenia gravis. It differs completely pathophysiologically because the weakness associated with Lambert-Eaton syndrome is due to antibodies directed against presynaptic calcium channels at the neuromuscular junction. Patients often show an improvement in muscle strength with repeated usage. Reflexes can be decreased and males are more commonly affected than females, unlike myasthenia gravis. Proximal muscles are affected more in LE. LE is Lambert-Eaton syndrome. So it is associated with small cell lung cancer also. And the patients are often resistant to non-depolarizing neuromuscular blockers, unlike myasthenia gravis, who are super sensitive to non-depolarizing muscular blockers. So, patients with myasthenia gravis are often more sensitive to depressive respiratory effects of benzodiazepines and opiates. So, preferably they are to be avoided. And as I had mentioned, due to decreased amount of acetylcholine available, these patients tend to be resistant to depolarizing neuromuscular blocking agents like scoline and very sensitive to non-depolarizing muscle relaxant. So care must be taken during the induction and maintenance. Depending on the procedure, volatile anesthetics may provide sufficient muscle relaxation, as I had mentioned. So the anesthesia preferably to be given multimodal anesthesia. What is multimodal? If you are giving general anesthesia, give a bit of epidural anesthesia also. The idea is to decrease the sympathetic nervous system response to surgery, anesthesia, and decrease the overall stress response, which increases the problems with the myasthenia. So, no specific volatile agents is superior to any other. So anything can be given. So, the lung pattern is normally restrictive. And when you are giving rocuronium or vecuronium, which is preferable in such cases, when you are giving the Sugammadex is absolutely perfect. So, when it can avoid the bad effects of neostigmine. So, I would always advise Sugammadex usage for reversal instead of using neostigmine. So, the negative effects of neostigmine can be avoided by giving Sugammadex to reverse rocuronium or vecuronium. So I have told you the things which are very, very important. One more thing I would like to add is parturients, the pregnant people who are having myasthenia gravis. They can give their myasthenia gravis symptoms to their offspring. So preferably epidural is better to parturients in any surgery, in like cesarean and all. The maternal antibodies are normally passed through the placenta to the neonate, and that causes neonatal myasthenia gravis. And it can present as feeding difficulties with respiratory dysfunction. With obvious myasthenia gravis in a neonate won't be able to suckle for long. The disease is transient in nature, usually lasts only a few weeks. However, it may necessitate intubation or mechanical ventilation in the newborn neonate because of myasthenia gravis. I hope the topic was well covered, very information, very educative and informative. Thanks for patient listening, friends. Have a wonderful day. This is Colonel Pradeep Pindiala, Professor of Anesthesiology, signing off for tonight. Until next time, take care. Bye-bye.